pharmacy services comprise comprehensive oral care and treatment solutions. Korea's top-selling dental software, such as the electronic chart, dental office management software, and examples of a wide range of products provided by OSTEM. Further, OSTEM provides a dental office interior design solution that takes patient convenience into consideration. The solution ultimately the ideal clinic environment. OSTEM, the digital dentistry leader, offers innovative digital technologies and products, including computer-guided surgery, milling machines, 3D printers, and digital orthodontic liners. OSTEM's corporate dental portal, Demo, has been spotlighted as a one-stop platform that provides services and information, including education, news, recruitment, and software for clinicians. Advanced technology and premium quality are the drivers of OSTEM's development as a global dental leader. Securing a high-level dental laboratory, central lab, OSTEM now operates 15 dental R&D centers and invests 11% of corporate revenue in R&D. Top dental R&D researchers are striving to develop technologies and products that will lead the global dental industry. As a result, OSTEM has successfully established top-level implant technology and the largest implant product lineup around the world. OSTEM, the digital dentistry leader, established an R&D team for digitalizing dental treatment and improved its capability by setting up full digital dentistry product lines of equipment, materials, and total management software that can manage all clinical steps from diagnosis to treatment. While maintaining top-level quality, OSTEM has established global production bases in Korea, the US, and China, and is cooperating to achieve a better quality assurance system. OSTEM established a strict quality management system, which includes high-tech production automation system, total inspection system, and quality tracking system for each process. Perform strict quality control inspections for each production process and product to meet the highest standards. OSTEM also contributes to society. OSTEM's clinical education programs are designed to assist with providing better treatment for both clinicians and patients, and extensively contribute to clinical development for clinicians all around the world. Moreover, OSTEM is continuously expanding its social contribution by sponsoring community service activities and dental academic organizations. OSTEM has also donated scholarships to dental schools and graduate schools for clinical dentistry. OSTEM currently has 13 business sites in Korea as we continue to expand our network globally. The headquarters and central research lab, which is located in Abo, Seoul, is maximizing synergy by unifying R&D capabilities in all fields of dental services. OSTEM is the global dentistry industry by expanding its global network to US, China, and Europe, running branches worldwide and exporting products to more than 80 countries. OSTEM is securing the world #1 implant sales company status by experiencing remarkable growth every year. OSTEM Implant's vision does not stop here. OSTEM Implant will strive to develop better technologies to lead the global dental industry that will contribute to healthier life in the era of 100-year human lifespan. OSTEM Implant will advance to become the global #1 implant company by 2026 and the global #1 dental company by 2036. A company that is growing endlessly to become the global #1 in the dental industry. OSTEM Implant.
Hello, everyone. Good morning, afternoon, evening, everyone. Welcome to Austin Middle East Live Webinars. I am Dr. Stephen, Education Manager in Austin Middle East, and I would like to welcome you all, and I will be your host for today's session. At Austin Middle East, we are dedicated to delivering top-tier education to empower our dentists with the finest knowledge and expertise. As a part of this commitment, we are conducting our webinars to serve the Middle East customers. To provide comprehensive solutions designed to help build an industrial environment suited to the digital dentistry, Austin Implant will continue the R&D and innovations with passion and relentless determination to take on new challenges in the pursuit of new technologies. In today's session, we will dive into the world of dental implant technology. Over the next hour, we will explore the latest advancement and techniques reshaping the field of implant dentistry. Our topic today is optimizing implant prosthetics, a comprehensive approach to diverse clinical scenarios. Before we begin, allow me to introduce our esteemed speaker for today, Dr. Mohamed ElAshry from Alexandria, Egypt. He is a renowned expert in the implant dentistry with a long year of experience in the field. Let me introduce Dr. ElAshry. Dr. ElAshry, he is a BDS and a Master of Science Assistant Lecturer of Fixed Prosthodontics in the Faculty of Dentistry, Alexandria University, Egypt. A digital prosthodontist specialist, a private practice microscopic dentistry specialist at Elite Microscopic Dental Clinic in Damanhur, Egypt, and he is an Austin faculty member and key opinion leader. Thank you, Dr. ElAshry, for joining us today. But before we start, we have to, let me remind you with a quick note. We have to ensure our mic is muted all over the presentation to minimize the noise. And if you have any question, please leave it, write it down in the comment section. And Dr. ElAshry, he will reply to all your questions. Without further ado, let's give a warm virtual welcome to Dr. ElAshry. Over to you, Dr. ElAshry.
Hello, good afternoon, Stephen. Good afternoon, everyone.
Good afternoon, Dr. ElAshry. Thank you for coming today. It's a great pleasure to see you.
Thank you very much, Stephen, for this nice introduction, and thank you very much for the invitation for being with you today. I think this is the first webinar organized by Austin Middle East. So actually, it's my honor to be with you today in this webinar. And I'm looking forward to a good lecture and a fruitful interaction and a fruitful discussion by the end of the presentation.
Sure.
So let me introduce myself again, Stephen. I am Mohamed ElAshry. I am Assistant Lecturer of Fixed Prosthodontics at Alexandria University. And I'm honored to be one of the STEM key opinion leaders and faculty member in Egypt and in the Middle East. Actually, this is my first activity with STEM Middle East. I was honored to be in the first STEM meeting in the Middle East in Dubai last February. And I was honored to share the stage with my professor and my mentor, Professor Dr. David Chung, and also with Professor Dr. Marco Tallarico and Professor Dr. Yonjin Kim, and also my dear friend, Dr. Ahmed Ashraf. So today, webinar topic is optimization and how to optimize the implant prosthetics in diverse clinical scenarios, starting from the single crown to the full mouth rehabilitation with implants. And because usually as a prosthodontist, we have to restore the aesthetics, we have to restore the function, and also we have to restore the occlusion. And definitely one of the most important criteria that we want to achieve in our workflow is precision. So we need precision in the both steps and the both phases of implant restoration and implant placement. The first stage, which is the surgical phase, and the second stage, which is the prosthetic stage. So I am honored to work with one of the best periodontists in Egypt and in the Middle East, He is Dr. Ahmed Ashraf. We are working together since 5 years in 2 clinics, replacing more than 600 ostomy implants, which is fully documented from the planning to the surgical process to the prosthetic phase. We are trying to seek perfection in delivering the best functional and aesthetic result to our patient based on science and based on evidence-based protocol. So this multidisciplinary approach allows us to go back to our patient needs, because your patient came to your clinic is not seeking implants, he is seeking teeth. He needs function, he needs aesthetics, he needs to have teeth. So our rule to restore this patient teeth, he is not concerned with implant type, he is not concerned with implant connection, he is not concerned with the protocol of grafting or the surgery or even the type of the restoration. He is only concerned to have teeth. So me and the periodontist are trying to follow the success or key factor for successful implant, starting from the planning phase, starting from placing the implant in the ideal 3D position in the plan, which will facilitate the surgery and facilitate the prosthesis and maximize the potential of our restorations. And then the main concern of the periodontist, which is appropriate bone architecture and a stable bone volume, and also another concern for the periodontist to have an adequate thickness and the quality of soft tissue. And then my rule and my concern to select an ideal transmucosal form, material, and surface of the abutment. And then also my rule to preserve the soft tissue contour created by the periodontist by a kind of adhesion between the restorative material and the soft tissue. So the approach usually is prosthetic-driven approach through a planning triad starting from collateral aesthetics and tooth position, and then also planning for Stephen, please accept the one who want to enter the meeting, because it's disabled from here. I cannot make the presentation.
Sure, we are accepting.
So the planning triad starting from the tooth position and collateral aesthetics, and then the bone and soft tissue. Even we can plan for augmentation of the bone and soft tissue, and finally planning for the implant position, because usually bone and soft tissue will guide the implant position, and also the implant position will guide the final tooth position and the collateral aesthetics. So we are starting the planning triad from the end of the story, planning for the tooth position, then the implant position, then how to make and to place a soft tissue grafting or bone grafting to enhance our restorations. Stephen, I have the problem. I have a problem with doing the slides.
Yes, we see the slides. The tooth planning triad.
Because there's something to compare.
Everything is perfect.
No, I cannot make the slides.
You can't move?
I cannot turn on the slides, yes.
طيب ممكن نلغي الشير سكرين ونعمله شير تاني، متهيألي ممكن.
I cannot do this also. It's freezed. Yeah.
تمام كده ابتدى ينقل.
No, not the same.
Okay.
You can stop, share the screen from your side.
Actually, it stopped. For me, I stopped. Also your screen. انت برضه وقفنا الشاشة عندك. تمام.
Better now?
تمام.
So, for example, nothing can destroy the work of a good surgeon rather than a poor prosthetics. For example, the periodontist can place the implant in ideal position with a very nice bone, with a very nice soft tissue, but the problem is the prosthetics can destroy everything. For example, for this case, we have a very huge amount of excess cement at the level of the implant abutment connection, this excess cement will induce peri-implantitis with a further peri-implant tissue loss and further bone loss, and finally loss of the implant. So factors for the crystal or for maximizing the crystal bone stability are not only surgical. It's a combination between the surgical factors and the prosthetic factors. So my rule for today is to discuss the prosthetic factors for maintaining the crystal bone stability. I think as a periodontist, Dr. Ahmed has discussed most of the surgical factors in the last webinar regarding the soft tissue augmentation, either before or after implant replacement. And my role today is to discuss the prosthetic factors to preserve the crystal bone stability. So today's presentation is two parts. The first one is the prosthetic factors and how to implement these prosthetic factors with different clinical scenario to achieve the maximum potential of our restoration to preserve the crystal bone stability. Same problem. I have a problem with slides, Stephen. Cannot turn on the slides.
برضو نفس المشكلة.
Okay, so again, we are trying to simplify the prosthetic factors and how to implement these prosthetic factors in different clinical scenarios, from single crown to complete mouth rehabilitation with implants. And these factors are: the first one, retention type, to select screw or cement retained restoration, which is better than another in different clinical scenario. The second one is the emergence profile. What is the emergence profile? What is the ideal shape of the emergence profile? How we can shape and how we can duplicate this emergence profile? And then what are the ideal prosthetic material for different situations, and how we can achieve a proper barrier function for the supracrystal complex with the prosthetic material? And finally, the occlusion consideration. Definitely, occlusion can be a detrimental trigger for implant failure. So I'm trying to simplify the occlusal scheme for implant prosthetics. And as you know, these factors are very big to discuss in one webinar. So I'm trying to simplify each factor to get the maximum benefit of today's webinar. The first one is the retention type. Definitely, you know, we can use a stock abutment or stem of stock abutment or stem tie basis to make cement retained restoration. And definitely we can use a multi-unit with its tie base to make a screw retained restorations. And also we can make a combination between screw and cement retained restorations in a kind of custom abutment or scrementable restoration. Stephen, I have a problem. When you accept someone, I cannot control the slides. When you accept someone to enter to the webinar, I cannot continue to turn on the slides.
لا انت خلاص يعني سيبنا، بس هو ده انا لما بدوس ممكن ياخد 10 ثواني لحد ما بيعمل اكسبت لحد ف ف يعني انا بعملها فما تقلقش خالص.
انا قصدي ان هو بيقف خالص يا ستيفن، هو انا ما بعرفش اكمل سلايدز. الكنترول من عندي بيقف على سلايدز.
انا بس هعمل الاكسبت.
So we know that we have a long historical debate between screw and cement retained restorations. So according to this very famous systematic review, which have two main conclusions. The first one, that cement retained restoration have more serious biological complication like bone loss and implant failure, and bone loss more than 2 millimeters, and bone loss 2 millimeters and more, leading to implant failure and also peri-implantitis. And the main reason behind this complication is the excess cement. And also the major complication of the cemented restoration is the difficulty in retrievability of these kind of restorations. For the other side, for the screw retained restorations, definitely we have the same level of errors with complication, technical and biological. But the privilege for screw retained restoration is the restorability, that this complication can be treated if detected early through the retrievability of this kind of restorations. You can screw the restoration, you can unscrew the restoration for maintenance and for removal of the excess cement, for example. And among the factors and the selection criteria between screw and cement retained restoration, a very important factor and a very important criteria, which is the passivity of fit. Actually, passivity of fit is very important to consider during your restoration or when you are selecting to do screw or cement retained restorations. It's the same problem, Stephen. I cannot control the slides. After you accept, the problem here with me, I cannot turn on the slides.
طيب هو انت بتعمل اكسبت مظبوط كده؟
انا مش بعمل اكسبت خالص، انا بسيبك تعمل اكسبت.
مش بتعمل؟
لا.
هو واضح ان في تكنيكال ايرور بس
نجرب تاني كده. او ممكن تقفل you can lock the control for me to accept anyone.
اوكي
Makes
تمام.
control for you only, okay? From host tools. Okay?
تمام.
So sorry for this technical error. I'm going to start the webinar again. Okay. So among the selection criteria and the factors that controlling to select cement or screw retained restoration is a very important criteria, which is the passivity of it. Actually, passivity means that there is no any stresses or any strain at the prosthetic component or on the implant itself or on the peri-implant bone or the peri-implant soft tissue. And usually this passivity is impossible to obtain due to a lot of clinical errors and a lot of laboratory errors that cannot be controlled and cannot be decreased during our process, leading to a severe stress concentration at the level of the implant abutment connection, leading to screw loosening, deformation or fracture of the screw, or even peri-implantitis and bone loss. And one of the main advantages of the cement retained restoration is that cement layer can compensate for some of this misfit. So the only privilege for this cement retained restoration is the passivity of the restoration. But the main disadvantage is the retrievability of this kind of restorations. So we are trying to make a combination between cement retained restoration for its passivity and also a screw retained restoration for the ease of retrievability. So today we have a very nice concept of screw-montable restoration to get the maximum benefits of both type of connection and both type of retention. But to achieve a proper screw-montable restoration, you must place the implant in ideal 3D position. Because if you are placing the implant in a more buccal position, for example, for central incisor, the axis or a screw axis fall will be from the buccal surface, so it will interfere with aesthetics. So you have to place the implant, you have to plan to place the implant in the ideal 3D position, buccolingual and also mesiodistal. So after scanning with the very nice new scan body of stem implants, we can make cementation of the restoration over the stock abutment or over the tie bases with the screw axis hole to be able to screw the restoration intraorally. So usually you can do this scrementation over a stock abutment but the problem that the stock abutment is very smooth. So to enhance the weak layer of the cement between the restoration and the abutment, we have to make a kind of sandblasting, then applying metal primer to enhance the wettability of the resin cement to the surface of the abutment, and also make a kind of conditioning to the intelligible surface of the prosthetic material to enhance the bonding between the restorative material and the abutment. And usually, I like to make extra oral cementation for my restoration, especially for single crown. And I can take the privilege of this very nice digital analog of a stem implant with a very nice features, which is analog fixation screw from the bottom of the model. So I am placing the analog in the printed model and then placing the abutment and then cement the crown extra orally. And sometimes I'm doing this guide, cementation guide. This cementation guide can be done with any software with a slight extension to the embrasure to prevent any rotations of a crown. The main benefit of this guide is to place the crown ideally in its finish line on the abutment, because sometimes when placing a large amount of resin cement, it can create a kind of hydraulic pressure, prevent the seating or complete seating of the crown. So this guide will help me a lot to place the crown in its ideal position on the abutments without any gaps or micro gaps. So I am doing this with my microscope, placing the guide, remove the excess cement, and after complete curing, I can remove the guide and make finishing and polishing for the interface between the abutment and the crown to remove all the cement and to make a very nice polishing to enhance soft tissue adhesion, as I will discuss later on. So now I have a very nice connection, which is completely passive, that can be screwed intraorally without any complication. And anytime you can remove this restoration for maintenance or for follow-up, or even if you want to cement this restoration intraorally, you can remove it to remove the excess cement. The problem with the scremented restoration, especially for the anterior zone, is that when you are placing the implant with the long axis of the incisal edge, the problem here is that the screw hole will be at the incisal edge position, interfering with the aesthetics. Sometimes we can have the privilege of making angled screw channel, but this privilege will not be achieved unless this angle cannot be more than 20-degree palatable. Because if more than 20-degree, the level of angulation, we cannot make angled screw channel. Also, if this angle will interfere with the thickness of the incisal edge, we cannot make this type of restoration, and we can make a combination between screw and cement retained restoration, as I will discuss later on. So this is the scremented restoration with angled screw channel for anterior teeth. I think this was a fully guided protocol for this central with one guide kit. We place the implant and then the crown was already cemented on the abutment and screwed intraorally immediately after the surgery. And sometimes we can do this scrementation on this very nice tie base of Ostem implants. This Ostem implants has a very nice feature, which is this projection, anti-rotational projections, 3 anti-rotational projection to prevent the rotation of the crown. And also it has anti-rotational feature and retention features like these serrations to enhance the mechanical lock between the cement and the tie base. But if you want to use this tie base, you have to scan it with the one-use or single-use disposable beak scan body supplied with tie base. This is a very nice scan body because it's disposable, it's only single-use, so you are enhancing the scanning accuracy of your scan body, because when you are using a beak scan body and with many times of sterilization, it can affect the dimension of the scan body, so affect the matching accuracy between this scan body and the library in ExoCAD or even on 3Shape. Also, another problem with scrementable restoration is when you are trying to make a scrementable restoration for fixed partial denture, or even when you want to make a splinting between two neighboring implants. The problem here is the implant divergence angle. Because if you want to screment the restoration and remove it and place it again, the interferences of the implant divergence will disable this process. So If you want to make a scrementable restoration for fixed partial denture or for two splinted crown, for example, you have to know the conical connection and the angle of the conical connection of your abutments. Stem implants has a very nice feature regarding the internal connection, which is around 11 degrees more stable. So if you want to make scrementable restoration, the implant divergence angle should not be more than the sum of the opposing wall of the internal connection, which means if we have two divergence implants, the angle between them should not exceed 22 degrees, which is the sum of the opposing wall of the internal connection. So if you have two splinted crowns, if you have long span FBD with an implant divergence less than 22, we can do this kind of connection. And also we can use non-engaging tie base, a combination between non-engaging tie bases or non-engaging with one engaging tie bases, which according to this recent literature, I think this publications was published in this year, last February, discussing the misfit of non-engaging tie bases according stereomicroscopic assessment and the screw resistance test and radiographic evaluation, and the final conclusion that both engaging abutment combination or even tie bases tolerated different misfit level. So if you have a situation like this, if you want to splint two crowns, for example, for this case, we have to do connective tissue graft. So we have to do a bridge to condition the soft tissue and to condition for ovoid pontic sites. So we used two non-engaging tie bases, was screwed very easily after the surgery with very nice soft tissue outcome. Also for two splinted crown, especially for the posterior region, we can make a combination between engaging and non-engaging tie bases. The benefit of the engaging tie bases mainly is the hex type. The hex here in the distal abutment will increase the stability and the anterotational feature of your FBD or your splinted crowns. So usually in two splinted crowns, I use the distal one as hexed and the mesial one as non-hexed to fabricate scrementable splinted restorations. And you can see in the X-ray, very nice seating, which is completely passive restoration without any stresses at the implant abutment connection or at the peri-implant soft tissue or even the bone. And sometimes also for short span FVD, we can use the same combination between hex and non-hexed. The distal one is hexed and the mesial one is non-hexed to fabricate a completely passive restoration, which tolerate a high level of misfit with a very nice soft tissue contour around our restorations. But the problem is when you have a long span FVD with an implant divergence more than the sum of the conical connection of the two non-engaging tie base, we have to use a different kind of connection, which is a screw retained restorations over the multi-unit abutment. The multi-unit abutment is a very nice solution to splint different implants together and also for full mouth rehabilitations, because the taper of the parallel walls of the opposing wall is around 24 degrees. So it can allow for a path compensation up to 48 degrees, which is the sum of the opposing walls. So if you have a case with different implant divergence, if you want to splint with specificity, we can use the multi-unit abutment to fabricate anterior restoration or posterior restoration or even complete mouth restoration with implant. And you can use the tie base of the multi-unit, this tie base, to be screwed on the multi-unit. This tie base will be cemented in the intelligent surface of the restoration with the same protocol of bonding. And then this restoration would be screwed intraorally. The same technique of the surface treatment, sandblasting, and then making metal primer to enhance the wettability, and then also surface treatment for the zirconia or the different materials that you are going to use, and also priming for this intelligent surface, and finally bonding. And usually, if you are sure of the passivity of your model, I can cement extraorally depending on the cementation guide to remove any excess cement around the margin. So with the same protocol of cementation, I cement this restoration extraorally and then screw it in place. This is the sequence. This is a multi-unit. This is the scan body or stem scan body for the multi-unit. And these scan body are very nice because they are short. So they enhance the quality of the scanning, because when you have a long scan body, when you are moving from the soft tissue to the scan body, this jumping effect from the scan body to the soft tissue will decrease the trueness of the final mesh. So when you are using a short scan body, you can move in one stroke with the soft tissue and the scan body, so enhancing the accuracy of your scan. And then this is the hygienic cap, the healing cap for the multi-unit to prevent any food impaction in the screw hole. And now this is the final process, cementation extraoral, and you can see the very nice emergence profile after screwing the restoration. Only after 2 weeks, we have a very, very nice emergence profile. Also, we can use these multi-units in different scenarios, full mouth, all-on-4, all-on-5, all-on-6, these different cases with multi-unit abutments. Also, a very nice feature of these multi-units that we have two angulation, 70 degree, 17 degree, and 30 degree, that allow bath compensation up to 108 degree. Because if you are placing the implant with divergence 108 degree, the 60 degree abutments can compensate this, the two multi-unit abutment can compensate for 60 degree, and the remaining 48 degree can be compensated with the internal or with the opposing walls of the multi-unit abutment. So we can place the implant in all-on-4 concept with an angle, but should not be more than 108 degree divergence. And the most important thing during the planning, to place the ideal timing of the implant, to be able to place the implant in the ideal position regarding the flat surface and the hex, to place the implant in the ideal position to correct this angulation and to make the ideal bus compensation to be parallel to the remaining 4 implants. And the same for all-on-6 concept and all-on-X concept. You have to plan properly for the timing of the implant, especially if you are going to use an angled multi-unit abutment. And you can use this multi-unit with direct connection to the restorative material, or you can use it with direct connection also with a titanium bar with superstructure later on. Also, I like to use multi-unit abutment in splinting when you are doing complete mouth rehabilitation and combination between teeth and implants, because the multi-units facilitate the splinting and also distributing the occlusion stresses over large number of implants. Sometimes we cannot make a true screw-retained restoration. Sometimes we cannot make a screw-mounted restorations. And here we can make a combination between screw-retained restoration and cement-retained restorations by a mean of customization. So sometimes for single crown, we can make a customized zirconia abutment or customized titanium abutment according to the situation. The main advantage of the customized abutment is to correct the unfavorable position of the implant for a cemented restoration. For example, this implant was placed in a more buccal direction, so the screw hole is completely from the buccal side. So we can make a custom abutment to correct this angulation, and then you can cement a crown on top of this restoration. Also, a very nice feature from the custom abutment to shape the ideal emergence profile from the narrow implant diameter to the scalloped margin of your final crown. Here for a single center, for example, we have done a custom abutment to correct the angulation and to adjust the emergence profile, and then with a cemented least silicate crown on top of these restorations. Also, when you are placing an implant very deep in the soft tissue and you cannot make cement-retained restorations because of this cement may seep into the subgingival part and around the implant, leading to peri-implantitis. So we can make a custom abutment to allow for ideal control of the crown margin to be easily accessible during cementation to remove any excess cement around the margin. And usually I cement this kind of restoration with rubber dam to prevent the seepage of the cement below the undercut of the custom abutment. And now we have a very nice connection between the crown and the custom abutments, and between the crown and the abutment and the bone. So you can remove the excess cement very easily if you are doing a custom abutment with an almost equigingival or half millimeter subgingival. Another situation, placing custom abutment to correct the angulation. And finally, lithium disilicate crown on top of this customized abutment. Also, in many cases of aesthetic rehabilitation, the problem of the grayish titanium background of the abutments slightly makes the shade matching is very difficult. So I'm doing a custom abutment with a shade almost near the neighboring teeth to have a final restoration with the same translucency and the same shade. So custom abutment here is to correct the angulation and also to adjust the shade of the final restorations. Also, for fixed partial denture, we can make a kind of customization. Like for this situation, we have two implants with large divergence. So I place two custom zirconia abutments, almost with the finish line subgingival half millimeter, with a common path of insertion, so the restoration can be cemented very easily. And usually, my recommendation for this kind of restoration is to cement this restoration with a long-term temporary cement, like Dento Temba from Itira, for example, because in the maintenance or in the follow-up, I can remove this bridge, I can make some cleaning, and also I can return this bridge again. So long-term temporary cementation is very nice for this kind of restorations. And the sequence is scanning of soft tissue, scan with the scan body, and then making custom abutment with ideal emergence profile according to the static biological contour concept to correct the implant angulation, and also to make ideal control of the margin, and to make a smooth transition from the flat symmetrical shoulder of the implant to the ideal emergence profile, and then scanning of this abutment extraorally to be matched with the intraoral scan very, very easily, and now you can cement the restoration with a complete specificity. I like this solution in longer span restorations, and also I like this kind of temporary cementation of the final restoration to be easily retrievable. Also, for the anterior restoration, we can make splinting of these two implants with a fixed partial denture. So we are doing a customized zirconia abutment with a common passive insertion, then cementation of the final lithium disilicate fixed partial denture on top of these restorations. Also, we can make customization with titanium abutment. But the problem is when you have a very thin biotype, when you have a thickness of less than 2 millimeters, the soft tissue will be conditioned with the color of the grayish discoloration of the titanium abutment, leading to a kind of grayish discoloration of soft tissue. So if you want to do customized zirconia abutment, or sorry, customized titanium abutment in the anterior zone, you must make sure that you have a very thick biotype to avoid discoloration of soft tissue by the background color of the grayish titanium abutment. Sometimes, if it's obligatory to do customized titanium abutment, you have to make some anodization of the subgingival part to condition the very thin biotype to a pinkish color rather than a grayish color of the titanium abutment. So in this situation, if you have to make custom titanium abutment in a very thin biotype, it's better to make anodization to the subgingival part of the abutment. And here, if you want to select between customized zirconia abutment and metallic abutment, what is the ideal connection type? What is the ideal material for connection, from zirconia or from metallic? Actually, even with a very nice internal connection, with a very nice 11-degree more stable of stem implants, we have a kind of micro motion leading to micro gap. And this micro motion can cause a slight bumping of the saliva and bacteria into the connection between the implant and the abutment, leading to a lot of biological complication. So when we are using customized zirconia abutment with customized connection, the problem is the micro motion. This micro motion will create a kind of abrasion of titanium at the level of this connection in a phenomenon called fretting wear. This abraded titanium will participate in the soft tissue around the implant, leading to severe discoloration of the soft tissue, especially when we have a very thin biotype. So we lost the main advantage of the zirconia abutment, leading to more mechanical complication and more biological complication. So if you are going to do customized zirconia abutment, it's better to use it with internal metallic connection to decrease these biological and mechanical complications. Also, for a full arch restoration, when you're having an implant with a severe divergence like this, the implant is placed bone-driven, not prosthetically driven. So each implant have its own long axis. In this situation, I like to make customization of the abutments to make abutment, titanium abutment with a common bus of insertion. So in this situation, any problem in the bus of insertion can be compensated with the cement layer, so we can have a very passive cemented restoration in cases of full arch rehabilitations. So for full arches, you can use a multi-unit to correct the angulation, or you can use customized abutment with a cemented restoration to correct these angulations. The second factors for today's webinar, or for the prosthetic factors, is the emergence profile. We have three concerns regarding the emergence profile. The first one, what is the emergence profile and what is the ideal shape of the emergence profile? The second important factor is how to produce and how to duplicate this emergence profile. And finally, how to achieve attachment to the prosthetic material with the soft tissue, with the prosthetic material, and how to select the prosthetic materials. Actually, emergence profile is the 3D transition from the flat symmetrical shoulder of the implant to the scalloped margin of your crown. So the healed peri-implant mucosa and the buccal aspect average from 3 to 4 millimeters from the crest of the soft tissue to the implant platform. And usually we have 2 to 3 millimeters of horizontal thickness in case of thick biotype to avoid exposure or to avoid conditioning of the soft tissue by the background color of the abutment. So according to Raymond Gomez-Mida, we have a very nice concept, which is a static biological contour concept of the emergence profile of the implant restorations, which is have 3 main zones, EBC zones, the famous EBC zone, the first one, which is the crystal zone, and the second one, biological boundary zone, and the final one, E zone, which is for static conditioning of the soft tissue. So if you are placing the implant now, during your planning phase, you have to plan this implant in a 4 to 5 millimeter deep from the crest of the soft tissue, to have 2 millimeter for the crystal zone for connective tissue attachment, and 2 millimeter for the junctional epithelium for the B zone for biological zone, and finally 1 millimeter for the circular epithelium. Because usually this supracrystal complex have a very nice function, which is a barrier function. We have to achieve a proper attachment between the restorative material and the soft tissue to act as a barrier for a physical and biological and mechanical function, and to avoid any bacterial infiltration to reach to the implant abutment connection. So for this case, for example, we have a very nice soft tissue with a depth almost 5 to 6 millimeters. So we have to shape the emergence profile zone to be able to enhance the barrier function of this supracrystal complex. For the first zone, for the crystal zone, it's related to the abutment height. So according to the literature, the abutment height should not be less than 2 millimeters, because when we are increasing the abutment heights, we are definitely decreasing the stress on the crystal bone, so enhancing the crystal bone stability. So if you are selecting an abutment for your implant, it should be not less than 2 millimeters of collar height to avoid any stresses on the surrounding crystal bone. And then for the B zone, the biological zone, which is the zone of divergence. The angle of the divergence of your final crown is very, very important. And also, according to literature, this angle should not be more than 25 degrees. In normal ideal 3D position implant placement, this angle should be 25 degrees, not more. Sometimes we have a kind of modification if the implant is placed very deep or if the implant is placed too palatally or too buccally. But the normal to make the emergence profile not more than 25 degrees. But why 25 degrees? Why especially 25 degrees? According to this very nice publication by Dr. Gary Goldstein, which is called the finding Z. Z here is the amount of vertical soft tissue loss, peri-implant loss, after delivery of the final crown, which is related to 3 important factors. The first one, implant depth. The second one, abutment width. And finally, the emergence angle. And according to his finding, he found that when you are placing the implant for 5 millimeter depth with abutment width not more than 2 millimeter, with divergence angle for less than 25 degrees, we have insignificant peri-implant soft tissue loss, which is 0.4 millimeter. But if the implant is slightly shallower, if the abutment width is slightly larger, 3 millimeter, with divergence angle more than 24 degrees, the peri-implant soft tissue loss and Z is very significant here, which is 1.4 millimeter. So we have to take care of the implant placement to the ideal epicoronal depth, and also we have to take care of the emergence profile angle during fabrication of your final crown, which is very, very important to consider. So after scanning, we can determine the EBC zone in the designing software to make the ideal shape of this emergence profile, to have this very nice crown with ideal emergence profile divergence. And for example, for this video, we can see the impact of increasing the emergence profile angle leading to a peri-implant soft tissue recession, with increasing this angle from 25 to 50 degrees. And now the question is how to shape and how to create this very nice emergence profile angle. Actually, we have 2 techniques, one immediate and one delayed. One immediate during implant placement with highly polished, customized composite abutments, or delayed at the time of the prosthetics with the final zirconia crown can shape the emergence profile according to our need. So during the surgery, we can make this very nice, customized, highly polished healing abutment with composite. So after extraction and filling the jumping gap with xenograft, we can place this very nice, highly polished, customized composite abutments to shape this emergence profile with very nice EBC zones. Here we can have a very nice crown with preserved soft tissue contour. Also, another case with the same protocol, after extraction, highly polished custom healing abutment, and then after 3 months of healing, we have a very nice soft tissue contour. Also different cases with the same protocol, custom healing, and then very nice soft tissue contour at the emergence profile, and the same for the anterior zone. Also, we can shape the emergence profile by the temporary restoration. We can shape the emergence profile and the temporary restoration even in multi-unit abutment to shape the ideal emergence profile and to shape the ideal zenith point according to the smile design that we have done before initiation of our treatment. Sometimes we can shape the crowns, we can shape the emergence profile with the emergence profile of the crown itself. So we can create emergence profile zones in the zirconia crown and then screw it with a scrumentable technique to shape this very nice emergence profile after 3 weeks of healing. So after making scrumentation, making ideal finishing and polishing, we can screw the restoration in place to have this very nice soft tissue contour. We have a lot of cases with this protocol to achieve this very nice emergence profile with a very nice attachment to the soft tissue to the restorative material. Also another case with a scrumentable splinted restoration. Also you can see here the narrow emergence profile and how we can shape the emergence profile to the ideal EBC zone or biological aesthetic contour concept. So you can make a kind of comparison between the pre-scrumentation and post-scrumentation regarding the emergence profile. And here you can see that we have expanded the emergence profile to around 1.5 millimeters, so enhancement of soft tissue and enhancement of soft tissue attachment to the restorative interface. So the sequence is scanning of the soft tissue, and then scanning of the scan body with a very nice new scan body of stem, then making custom abutment. This custom abutment here have two rules: to keep the subgingival part from zirconia to shape the emergence profile, and also to have a common bus of insertion for a cemented fixed partial denture later on. And here you can see the very nice emergence profile created by the customized abutments. But now, if you are creating an emergence profile with the custom healing abutment with composite, how to duplicate this emergence profile to the final restoration? Actually, with conventional impression, we can make some customization for the impression boost to be duplicated to the cast. But nowadays, with your scanner, you can scan the scan body and you can scan the soft tissue. Here I'm using Medit intraoral scanner, so I can scan the soft tissue after removal of the custom healing abutment, so it can preserve the contour of the emergence profile. And then I can take this STL or BLY to the ExoCAD to make a very nice EBC zones according to our needs. 2 millimeters for the C zone, 2 millimeters for the D zone, 1 millimeter for the E zone. And then delivery of the final restoration. So it's much easier to scan the emergence profile rather than making customization of the impression boost and take conventional impression. Here we are shaping the emergence profile zones. And then moving to the next factor, which is a very, very high importance, which is the prosthetic materials. Actually, prosthetic material is very important to achieve the ideal adhesion between the both interfaces, the soft tissue and the restorative material. Because we might or we must have a kind of surface roughness, micro surface roughness to enhance the adhesion between the soft tissue and the restorative material. And also, this micro roughness is critical, not to increase the adhesion of bacteria and not to increase more bacterial adhesion or infiltration. And according to literature, this micro roughness should be 0.2 micron, which is the surface roughness of the stock abutment and the highly polished zirconia. So can we use glazed zirconia at the level of the connection between the implant and the abutment? Definitely no, because the surface roughness of the glazed zirconia is 0.7 micron, which is very low. And according to studies, this surface roughness will not induce attachment. This surface roughness will have a higher tendency to probing depths and also bleeding and probing. So if you are doing crowns with zirconia, it's better to keep the subgingival part glazed and supragingival part, the subgingival part polished and the supragingival part from any type of material. Sometimes we can see this little bleeding. This little bleeding indicate attachment. So if you are doing the restorative material with a kind of micro roughness, this attachment, you can see it in this little bleeding after removal of your crown. So this little bleeding, not profound bleeding, can be seen if you have a good attachment between the restorative material and the soft tissue. And the best material to make this attachment is zirconia. So polished zirconia has the lowest surface free energy compared to other subgingival material, even titanium. So zirconia is better in attachment than titanium, still comparable to titanium, but it's better for a good attachment between the soft tissue and the restorative material. That's why the surface roughness is good for attachment and not good for the bacteria to adhere to its surface. So we can enhance the adhesion to the soft tissue and decrease adhesion to the bacteria. So in case you are doing customized zirconia abutment, keep the subgingival part glazed and supragingival part from any kind of material that you like. to achieve this very nice attachment to the soft tissue. And this is the soft tissue attachment to the titanium abutment, almost a little attachment with little bleeding. That's why zirconia abutment is much better, especially glazed zirconia abutment to, polished zirconia abutment to enhance the attachment to the soft tissue. So usually keep the subgingival part polished and the supragingival part glazed. And finally, the last factor and the most important factor and the detrimental trigger of implant failure, which is the occlusion. Actually, adjusting the occlusion scheme can start from the planning phase itself to avoid this detrimental failure, which is severe bone loss, peri-implantitis, peri-implant soft tissue loss can lead to implant failure. So adjusting the occlusion usually start from the planning itself. So, for example, when we have a case like this, when we have to raise the vertical dimension and when we have to place the implant, we have to start first with adjusting the occlusal plane. To place the diagnostic wax hub with the ideal occlusal plane and then to place the implant perpendicular to this occlusal plane to avoid any vertical or horizontal offsets, which might affect the quality of the connection between the implant and the abutment and leading to concentration of more stress at the crestal bone. And also, if you want to raise the vertical dimension, and usually I use a fascial-driven approach to raise or decrease the vertical dimension, you have to select the ideal vertical dimension because changing the vertical dimension will change the level of the occlusal plane and hence it changes the level of the long axis of your implants. So every case with a full mouth rehabilitation, you have to start with ideal smile analysis, vertical dimension analysis, and then you have to adjust the occlusal scheme according to fascially driven approach. So usually for full arch implant restorations, before starting to place the implant at the planning phase, I use the fascially driven approach to place the wax up according to the Camber's plane, which is the ideal occlusal plane, to place the implant later on with perpendicular to the long axis of this occlusal plane. So adjusting the occlusal plane, even in normal cases, to be with the long axis of perpendicular to the implant is very important to decrease any vertical or horizontal offsets. Also, from the planning, selecting the wider diameter implant, if possible, is very nice to decrease the forced concentration at the crestal bone or even at the peri-implant soft tissue. So when you are selecting to place the implant, it's better to select the wider diameter to be able to distribute the forces on a wider areas. Also, during planning phase, it's very, very important to detect and to determine the prostatic space, because sometimes in full arch cases, we have a very large prostatic space to make a kind of vertical offset and leading to severe concentration of the forces, leading to subsequent implant failure. So in a cases when we have a vertical space more than needed, it's better to use another kind of restoration or even to make a vertical bone grafting to decrease this area for prostatic space. This is because bone is much, much stronger under compressive forces rather than shear forces. So if there is any shear forces from lateral cantilever, this will make a kind of overload and microstrain at the implant abutment connection, leading to severe bone loss. So after implant placement, after delivery of the final restoration, you have to adjust the occlusal scheme to minimize the occlusal forces to avoid your implant failure. Because yes, the occlusion can lead to implant failure after even a very nice implant placement with a very nice bone architecture and a very nice soft tissue. So it's very important to minimize the occlusal scheme, eccentric and the eccentric forces. And you must have the basic knowledge of how to adjust the occlusal scheme. Usually, we must have a minimal centric contact to accommodate the teeth or the movement of the teeth within the elasticity of the BDLs. And usually, I like to confirm this kind of centric contacts with two digital methods. The first one with occlusal analysis software of Medit intraoral scanner, and then with an occlusensor, which is a digital sensor that can quantify the forces on each teeth in a separate way. So for example, this implant on canine, after verification of the occlusal contact, we have a premature contact on this canine with complete occlusion, with incomplete occlusion of the posterior teeth. So when confirmed with occlusensor, we have a high bar of forces on this canine with incomplete occlusion of the posterior teeth. These heavy centric forces will place a very high stresses at the level of the connection between the implant and the abutment, leading to peri-implant bone loss. So after adjustment, we have a completely occluding posterior teeth with a little contact on the anterior teeth, especially the implant on the canine. Also, it's very important, especially for the anterior restoration, to remove any eccentric interferences without affecting the quality or without affecting the final shape of your restorations. So, for example, for this case, this lateral is an implant, so we have to confirm that during lateral and protrusive movement, we have any kind of eccentric interferences to avoid microstrains at the level of the connections. And now moving to the complete mouth rehabilitation, and regarding the occlusal scheme does not mean the vertical stops or does not mean the centric stops only. Occlusal consideration start from the vertical dimension and the centric relation. Sometimes, if you want to record the centric relation for a complete mouth rehabilitation with implant, sometimes you are lucky to have the patient denture to use it as a custom scan device to the ideal vertical dimension with ideal centric relation. So in this case, for example, the patient has already a denture, so I use this denture as a custom scan device to scan the scan body with the ideal vertical dimension of occlusion with the ideal centric relation. So in this situation, I can scan the upper arch with the custom scan device, and then scan the lower arch with the custom scan device, and then occlude. Now I have very nice occlusion. Now moving to the upper arch again, remove the custom scan device and scan the soft tissue. And for the lower, it's very important to have what we called continuous scanning strategy, because this custom scan device will help to stitch between the scan body to another. And now I have the occlusion. And then the final stage to remove this custom scan device and scan in between the soft tissue. Now the scan body are locked. So the connection or the stitching is very easy to achieve in ideal vertical dimension and in a very, very nice centric relation. Sometimes, because I work with a lot of periodontists, so sometimes the case is referred to me without any record to the vertical dimension. And the multi-unit already is fixed, so I cannot make a complete denture to adjust the vertical dimension. So sometimes we can use wax rims. Although wax rims is very soft, and you cannot depend mainly on the wax rims, because sometimes we have some distortion, like in this case. After we use the wax rims, we have a heavy occlusion here and very light occlusion here and the anterior interferences. So now you have to fabricate a device to record this vertical dimension or even modify this vertical dimension in an ideal centric relation. So I fabricate my own Gothic arch tracer using Method Design software. So this is a bar fixed in place intraoral, and this is the design of the bar. I use the superstructure, the STL of the superstructure, to fabricate customized Gothic arch tracer for every single patient. So with mesh mixer or with blender or with Method Design, we can fabricate this pin with different height to record the vertical dimension. This pin will be fixed in this part of the Gothic arch, will be as a one piece. This is the superstructure cut from the occlusal surface to place this flat surface, and then placing of this pin. And now I have flat surface in the upper part of the maxilla, and now I have a pin in the lower part of the mandible. I can print this device and then placed or cemented on the final bars. And then this part of the maxilla is sprayed with occlusion spray, and I am let the patient to move in protrusive and in lateral movement. As you can see, the pen is now carving in the spray in the maxilla. And now I can record the centric relation. If you know this shape, this is the position of the centric relation. This is the protrusive path, and this is the lateral movement. This is the centric relation because the centric relation, according to Peter Dawson, is a repeatable reference position. So now I can record the vertical dimension according to the desirable height of the pin, and also I can record the centric relation depending on the patient movement. So again, scan the lower bar, scan the upper bar, let the patient move, fix this movement, the final centric relation with composite restoration, and then scan right, scan left. I have the ideal relationship. I can complete to the final restoration with a very, very, very nice occlusion. And then make sure of the statics, make sure of the vertical dimension, patient smile, everything is good. Now proceed to the final restoration, which is zirconia superstructure cemented on metallic titanium framework, which will be directly screwed in the multi-unit. So we start from here with no reference of the vertical dimension. And now we have this very bad vertical dimension and very bad occlusion stoppers. And now we have corrected this vertical dimension and centric relation to achieve this very nice final restorations. Also, for a single arch of implant, I can make this custom device directly screwed on the multi-unit. This is spray, let the patient move. You can see the movement, the arrow of movement, the centric relation, lateral movement. This part is a splint fixed on the lower. Here you can see the movement. This is the centric relation, the same shape, protrusive movement, lateral movement, and this is the custom scan device screwed directly on the multi-unit to record the vertical dimension and also the centric relation. So this is the end of my presentation today. I tried to simplify all the factors in a very short time. I think we may have the chance to discuss every factor in a separate way in a next webinar. I think we have to discuss everyone in a separate lecture because we have a lot of factors to discuss more. So today I tried to simplify the prosthetic factors and how to implement these prosthetic factors in different clinical scenarios, from single crown, splinted crowns, or even fixed partial denture to the final restoration. I was honored to be with you today, and I am looking forward to a fruitful discussion and a discussion to answer your questions now. And those are my QR codes for my Facebook account and my Instagram accounts. So I'll be very happy to send me questions to answer you anytime through my social media accounts. So thank you again. Thank you for your time. Thank you, Stephen and Dr. Ashmi, for this invitation. And now I'm ready for any questions.
Okay, thank you very much, Dr. Mohamed ElAshry. The presentation was straightforward and full of very nice tips and tricks. I believe we learned a lot today.
Thank you very much, Stephen. Thank you very much.
Thank you. So let's jump straight to the questions. We have got a few questions from Dr. Mustafa. The subgingival part of the customized pink abutment can be polished easily or not to prevent inflamed gingiva.
Actually, the zirconia abutment, you have to polish the subgingival part of the zirconia abutment. For your stock abutment, the stock abutment already have its own surface roughness, which is around 0.2 micron, which is ideal for surface roughness. So you can polish, but to a limit. You cannot make it highly polished to enhance the attachment between the soft tissue and the surface of the abutment.
Okay, we have another question. How can I transfer this movement to the lab? I think I was talking about the last point.
Yeah, you cannot transfer the movement to the lab using, if you are using a 3Shape or using Medit intraoral scanner, you can transfer this movement but the problem was not the movement. The problem is with the centric relation. So after the patient moved to the ideal centric relation, we can fix this position and then translate the whole relationship, the whole static relationship, which is most important, not the movement. We can adjust the movement later on, but now the most important thing is to transfer the vertical dimension in the ideal centric relation.
Okay, we got also another question is pink anodization. What is this?
Yeah. Pink anodization is a kind of bending of the subgingival part of the abutment with you can submerge the abutment in a solution like electrodes, and this solution will precipitate a lot of ions on the surface of subgingival part to cover it with a color like pink, like gold, according to the time of anodization. So you can do it to condition the subgingival part of the abutment, and to condition also the supragingival part of the abutment if you want to make it gold for a nice shade matching or for a nice background to the lithium disilicate crown without affecting the final color of your restorations.
Okay, thank you, Dr. ElAshry. We have also another question in the bridge cases with a link abutment. Does it matter to use the hex and the non-hex, like mesial or distal?
Actually, it's better to be in the distal, but the main problem regarding the part of the hex and non-hex is the path of insertion. You can select which one as an easier path of insertion, the mesial or the distal. The easier with the long axis of the path of insertion should be hexed, and the other one should be non-hexed. So it's better to keep it distal, but it's much important to preserve the path of insertion of your bridge. So the hexed usually with the ideal path of insertion.
Okay. Also, we have one last simple question is saying, can we use the tie base in a conventional cases?
In conventional cases, what do you mean by conventional cases?
I think he means the not digital, like the analog way.
Yes, you can use it in conventional cases. Yes, you can use it. It's already found in the library. And also the tie base is very important in cases that you have a very short prostatic space, because the tie base is slightly short. So when you have a prostatic space less than 7 or 6 millimeter, you can place the tie base because you need 2 millimeter of collar height and 3 to 5 millimeter of the tie base and 2 millimeter of restorative material. So tie base is very nice in a cases of short interocclusive distance or occlusal space.
Okay, thank you very much, Dr. Mohamed ElAshry, for answering all these questions. It was very interesting lecture, and it was even the Q&A session was very interesting.
Thank you, Stephen. Thank you very much for the invitation for this webinar, actually.
This is our great pleasure to have you today with us, and thank you everyone for attending today's webinar. Make sure this webinar will be uploaded in the YouTube. It's already live streamed, so you can come back and check anytime. So you can learn a lot for the tips and tricks, and we have a lot of I've learned today, like the zirconia, the glazed surface and the polished surface. There's some tricks and tips I think is very useful for us.
Thank you, Stephen. Thank you very much.
Okay, thank you, Dr. ElAshry. So before I end today's meeting, I want to announce about our upcoming events. So here in Dubai, we have there's exhibition in Dubai in November, in 15 and 16 November, and also 14 we have a hands-on session by Professor Marco Talarico. He will also give a lecture during the exhibition. And Austin has a stand or booth in stall number 24, 25, 26, and 27. This will be immediately in front of you once you enter the main gate. Also, I want to announce that we have Austin meeting in Tunisia This is the end of this year. It will be in 21 and 22 of December in Tunisia. If you want to participate, you can contact your dealer in your respective country. Also, I would like to show our OSTEM newsletter for the September. We are promoting the EOS and the CAS kit. I guess many of you already know about the CAS kit, which is very nice for the crystal approach sinus lifting without perforation. And this is our social media channels. You can freely scan them and communicate. If you have any inquiry about our products or our events or future events, you can communicate through these channels. So thank you, everyone. And thank you again, Dr. ElAshry, for being with us today. And thank you, everyone, for attending and for giving a very important presentation from Dr. ElAshry. Thank you very much, and see you again in the next webinar.
Goodbye.
Thank you, Dr. ElAshry.